Ma'am, we good to go.
Okay, thank you. Good evening, doctors. I'm Dr. Prajakta Wangikar, Medical Advisor with Emcure Pharmaceuticals Limited. A very warm welcome to all of you on this digital platform for another exciting session from No Thrombosis Workshop Series in Acute Ischemic Stroke. It gives me an immense pleasure to welcome our course director, Dr. Ichapuria sir, who is a director of neurology department at Sahyadri Hospital, Pune. He has more than 40 years of experience and has established first neuro-intensive care unit in Pune. He is a pioneer in thrombolysis treatment for stroke in India and has delivered more than 300 public lectures as well as conducted several workshops on stroke. He is a member of Indian Stroke Association and has served as the organizing president of StrokeCon in 2012 as well as ISA Stroke School. He is a founder of the Pune Stroke Group and has served as a president of the Society of Neurosciences and Maharashtra Academy of Neurology in the past. He is a principal investigator for many clinical trials like PERFORM, BrainsGate, cortical venous thrombosis, Interact2, and several other clinical studies. Recently, he has been awarded as a health icon by the Times of India Group. Sir, it's a great pleasure to have you on board today. Thank you very much for joining with us today.
Thank you. Thank you so much for the kind introduction.
Yeah. Just a second. I'm not able to see the screen. Yeah. So moving ahead, I would now like to introduce our moderator for today's session, Dr. Atul Prasad sir, who is a Principal Director and Head of the Department Neurology at BLK Max Super Specialty Hospital, New Delhi. He has over 33 years of experience in the field of neurology and is a member of renowned medical associations that includes Indian Academy of Neurology, Neurologist Society of India, as well as Indian Epilepsy Association. Before his association with BLK Max Super Specialty Hospital, he has also served as a senior consultant and head of neurology at Fortis Hospital and Fortis Escorts, New Delhi. He has several years of teaching experience and has delivered more than 40 talks at various forums, including national and international conferences. He is a principal investigator and co-investigator for many projects in neurology, including valproate in partial epilepsy, as well as stroke observational program in Asia. He has around 40 publications and 20 book chapters to his credit, and his areas of interest include movement disorder, that includes Parkinson's disease, as well as acute ischemic stroke. Welcome, sir. Thank you for joining with us today.
Thank you.
Now, I would like to introduce our second moderator, Dr. Dhananjay Duberkar, who is a senior consultant neurologist at 9 Pearls Hospital, Nashik. He's a renowned neurophysician with more than 10 years of experience. Earlier, he was associated with Grant Medical College and Sir J.J. Hospital as a resident doctor for 3 years and had also served as a lecturer in the critical care unit for a year after completing his MD Medicine. He was associated with the Postgraduate Institute of Medical Education and Research in Chandigarh as a senior resident neurology for 3 years and has performed more than 50 thrombolysis so far. He is a recipient of Pfizer Award for Best Medical Graduate in his academic career and has presented his work in neurology at various national as well as international conferences. His areas of interest include acute stroke cure, neuroinfectious diseases, Parkinsonism, and related disorders. Thank you, sir, for joining with us today. Welcome. So today we have two eminent speakers who will be delivering their talks on different cases, difficult cases to handle in acute ischemic stroke. So I'm very glad to introduce our first speaker, Dr. Chintan Prajapati, who is a renowned neurologist at NeuroCare Brain and Spine Clinic, Ahmedabad. He completed his fellowship in National Board in Neurovascular Intervention from Narayana Health City, Bangalore. Earlier to that, he was associated as a consultant neurologist at Neurovan Stroke and Critical Care Institute in Ahmedabad. He is a recipient of International Scholarship Award by American Academy of Neurology Annual Conference held at Philadelphia, USA in the year 2019. He also has presented his work in neurology at various national and international conferences and has around 14 publications, including original papers as well as book chapters to his credit. Welcome, sir. Great pleasure to have you today in this meeting. We have a second speaker today, Dr. Aradhana Chauhan, who is a consultant neurologist from Sahyadri Super Specialty Hospital, Pune. She has more than 8 years of experience in the field of neurology. She has completed her graduation from the esteemed institutes like D.Y. Patil, Pune, and from KM Hospital, she completed her DNB Medicine and DNB Neurology from Sahyadri Specialty Hospital, Pune. Thank you, ma'am, for joining with us today. And without further ado, I would now request Dr. Ichhapuria, sir, to continue the session. Over to you, sir. Thank you.
Thank you for the introductions. And we are really very happy to be part of this no thrombosis webinars, which have been going on for the last 15 to 16 months. And it's been every month we've been having, and we've had some fantastic cases, something very, very amazing cases that we have discussed and we have talked about, and it goes late into the night. And I think many people are benefiting from this and learning, and we are learning also. And of course, the person who presents learns the most. So we are very happy to be part of this program. And I very warmly welcome Dr. Atul Prasad. I think he's the first time he's been a moderator, and I'm sure you will learn a lot of things from him, and he will also from this group, and also Dr. Dhananjay Duberkar. Dhananjay, are you there? Dhananjay, are you there? Okay.
He has joined, sir.
Has
So you
joined,
need to unmute, Dr.
Yeah.
Dhananjay.
So,
Yes, sir.
yeah. So he's a very
Hello,
well-known neurologist, and we call him Danny, and he's absolutely brilliant, and we are very, very happy to have him also as moderator. I think you are the moderator for the first time. So we will have a very good session, I'm sure. And shall I request Dr. Chintan to present his case? Share your screen and present your case, Chintan. Before that, Dr. Atul Prasad, would you like to say a few words?
No, I think we can start off. It's even though I'm moderating for the first time, I have been part of the listening group. There's something wrong with my video, so I don't think you guys can see me. But anyway, I think it will be a wonderful experience. Anybody who works on acute stroke, every case is a challenge. Every case is different, and I think we all learn from each other. We learn stroke by stroke. So let's see what the guys have to present today.
Yeah. Dr. Dhananjay? Dr. Dhananjay? Okay, Chintan, I think we can start.
Yes. Am I audible, sir?
Yes, you are audible.
Yeah. And can you?
Yeah, we can see your screen. Yeah.
Yes, sir.
Yeah.
So I'm presenting a case where I had a doubt whether I should go with thrombosis. So I'll share the same and we'll discuss regarding it. So 71-year-old female, hypertension or diabetes mellitus.
Little loudly.
She was symptomatic for 9 months She was symptomatic for 9 months for breathing issues. There was breathlessness, coughing, and she was diagnosed with interstitial lung disease and idiopathic fibrosis. And she was on intent DARDIM. And recently, she was admitted and diagnosed also with pulmonary tuberculosis. And there was positive for gene expert. She was recently started on anti-tubercular treatment. And for last 1 week, she was having recurrent vomiting, intake, lethargy. This was going on since last 1 week. And this was the X-ray which was available in baseline. We can see there is right lower zone cavity and left pleural effusion. So now the neurological history starts. She had ability to speak, and followed in 2 hours by right-sided weakness. So she arrived in emergency department after 3 hours of onset of the symptoms. Blood pressure was 100/60, pulse were 110 per minute regular. Saturation was 90% on room air. She had expressed aphasia, left-sided gaze deviation, right facial weakness, and right hemiparesis. And there was profound weakness in upper limb. Power was 0/5 in upper limb, and lower limb it was total NIHSS was 17. Sugar was 158. So we went ahead with CT scan brain. As we can see, there is no IC bleed, no hyperdense arteries. And unfortunately, we could not perform CT angiography because we could IV access in either of the arms. She was malnourished, dehydrated. Her all upper limb veins were thrombosed because of recent. So we could not do CT angio immediately. So only plain CT scan we could do. There were no for intravenous thrombolysis. There was no recent bleeding, hemoptysis. Because she had a lung cavity, so I specifically asked whether there was any sputum or not. But relatives clearly denied there was no blood in the sputum at all. No head injury, no surgeries, and baseline she functionally independent. So at this point, I had a doubt whether I should go with thrombolysis or not, because in back of my mind, the possibility of tuberculosis, and it could be manifestation of pox also. Although there were no features of fever, headache, altered mentation apart from aphasia. So clinically, it was, but still there was possibility. I was not able to completely rule it out on the clinical basis entirely. So go ahead with MRI brain with angiography and contrast, but doing that we lost the window of thrombolysis, and there was a possibility of liver function. Recent administration of anti-tubercular treatment, and after that she had recurrent vomiting and function. There could be a coagulopathy, and it might lead to higher bleeding risk. So all of these things were going on, but I explained and they agreed, and they wanted to take risk and go ahead. So I thrombolized with tenecteplase 10 milligram bolus with a door to needle time of 42 minutes. And
what was her
there
weight?
was, in fact,
what was her weight?
Weight 40. So I administered 10 milligram.
Okay. Yeah. Please continue.
So over the period of 3 hours after thrombolysis, there was significant improvement in upper limb power. It improved to the extent of -4/5 proximally. Gaze deviation subsided, lower limb power improved, comprehension improved, and NIHSS dropped by 6 points. But there was again deterioration after 8 hours of thrombolysis, and NIHSS was 13. The baseline was 17, so she has still not reached the baseline and NIHSS. So there was still 4-point improvement from baseline. So we did MR next day. So IV thrombolysis we had done by a very small gauge cannula in leg. We could find one small vein, and we administered tenecteplase through the leg. So next day we did the MRI, and as we can see, there is a acute infarct in the left frontal, so precentral gyrus, and small infarct in right cerebellum also, as we can see. So we did TOF angiogram also, and there was no large vessel occlusion, and there was no significant atherosclerotic narrowing of any of the large vessels in the neck or the brain. So how did she have a stroke? So there was no atrial fibrillation on ECG. Her echo was normal. EF was HbA1c were within normal limits. What was abnormal was her D dimer was significantly raised. It was more than 10,000. CRP was 165, and there was hepatic derangement. Bilirubin was 4.1, and SGPT of 61. We did CSF also next day, and it was normal, acellular with normal protein and sugars. So what is the cause of the stroke? It is multi-territory. It is left frontal plus right cerebral infarct. So it has to be embolic, either cardioembolism or embolism from the aorta, or hypercoagulability secondary to inflammatory state plus dehydration plus nintedanib. So I went and reviewed regarding it. So actually, this nintedanib is a tyrosine kinase inhibitor. It has recently gained use in pulmonology for this idiopathic pulmonary fibrosis, and this is the website of Boehringer, who has developed the nintedanib. They are showing that there is in post marketing surveillance, there are incidences of arterial thromboembolic events after administration of this particular drug. So it is 2.5% in this drug compared to 1% in placebo. So it is still rare, but the thromboembolic events have been reported after use of this drug. So I reviewed the same, and the studies in pulmonology literature, they say that there are higher risk of myocardial infarction and other thromboembolic events in patients who receive this particular drug, especially in patients who have higher atherosclerotic risk factors. So finally, so that was the cause of the stroke in my patient, and this drug plus inflammatory state and dehydration, these all factors could have led to the stroke. The question is, will I do thrombolysis in this same patient again? Probably yes. But at the same time, it is also reported that this the use of this drug also shows higher risk. Thrombolytic events present with deficit, we should go ahead with thrombolysis. At that time, definitely the benefit of the treatment outweighs the risk. Thank you.
Dr. Atul, would you like to comment?
Yeah, a question. Would you put this patient on any long-term treatment, or will you just withdraw the offending drug? That is one. And second is, when the patient deteriorated Go ahead.
Yes, sir. So patient deteriorated after 8 hours. So we repeated MRI the next morning. So maybe after 2 to 3 hours of worsening. At that time, there was no bleed, and I think the infarcts were also of same age. So maybe the initial infarct only the same territory only, there was fluctuation. Maybe initially there was some penumbra, and after that there was a recanalization after thrombolysis, and again there was a thrombus. So I think, but that was happening in the same territory. And after doing MRI, we have started her on dual antiplatelets.
So would you, instead of dual antiplatelets, would you have preferred to put her on heparin for some time, because her D dimer was very high, and the mechanism is probably in hypercoagulable state?
Yes, sir.
I'm just thinking aloud. That's
yes,
for long term. After
yes,
the acute phase is over, after 24 hours, 48 hours, would you just dual antiplatelet does not make any sense, because there's multiple territories.
Yeah.
D dimer high, probably a course of a short course of anticoagulation. That is one question which the panel can discuss. Second is, when the patient deteriorated after the first thrombolysis, what went in your mind? Did you think whether you want to give a second dose of tenecteplase, or just too risky?
No, I was thinking of going ahead with terofibran.
agree. I have never given second dose of thrombolysis straight away. I think it's too dangerous. Playing with
Yes,
fire, she'll bleed, and she has this one also has liver dysfunction.
definitely. Yes, yes.
She would
And
have bled,
her
and
coagulation parameters are slightly deranged. Her INR is 1.5, APTT ratio is 1.6.
it's too risky. It's too risky. She would have bled this second dose. I think you managed it very well. There may be a difference of opinion on long-term management beyond 24, 48 hours with the antiplatelets or anticoagulation. I'm not sure what is the correct
So
way
another reason
forward.
I did not start anticoagulation was I had to plan for CSF. So that's why initially I did not start. But so this patient is actually admitted right now, and we have done CSF today only. She was admitted. She was thrombolized day before yesterday.
Is she improving? Is she doing well now?
Her NHS is holding on, sir. Now also it is 13. Baseline was 17.
Okay. I pass on. Dr. Ichapuria, do you want to comment on the second?
One or two points. First of all, I think you have done well by thrombolizing, because there's no definite contraindication. Unless, the patient is very moribund, and which was not the case. Is that correct?
Yes, correct.
Was she mobile prior to the event?
Yes, sir. She was functionally independent.
And what do you think her survival duration would be with the ILD? Approximately.
Sorry, sir. What was the
Was it a
duration with the
bad
ILD?
ILD or what?
Uh,
Was she breathless?
she was symptomatic for these pulmonary issues since last 9 months, and recently, since last 2 weeks, she was diagnosed with tuberculosis also.
Mm-hmm. Now, see, why is the D dimer so high?
Yeah, that's what, sir. So
when
that
this D dimer
nintedanib
is high and there are these multiple infarcts, you must think of malignancy. And, you must screen for malignancy, especially as she was, dehydrated and cachexic. Already, you said that, and her weight was only 40. So,
yes,
this
correct.
Actually three territory infarct. But when D dimer is so high, you must think of it is one of the markers of internal malignancy. So, many times we have found this malignant, this thing either in the ovary or, somewhere else, pancreas. So, screening for these things by doing a CT scan of the abdomen or doing those antigens for ovarian cancer. I think they are, there may be a hepatocellular CA also. This hepatic function was not good. So all these things you must think of. With this high D dimer, that means it is a hypercoagulable state.
Correct.
And it is likely that it is with that drug you said, cardiovascular things are there. So it could be a thrombus in the left ventricle or recent myocardial infarction or something like that. So maybe short-term anticoagulation would be in order, because the vessels look quite normal. So there's no vascular, intracranial or extracranial arterial involvement, at least on MRI. So, and because multiple vessels are involved, sudden onset, such a big stroke, NIHSS 17 means a severe stroke, more likely that it is cardioembolic or a hypercoagulable state. So I think anticoagulation would be in order. You could do a T or see for the left atrial appendage and do a long-term Holter to see for AF. What was the age you said?
71.
71. So, elderly females, elderly females, AF risk is definitely more than, especially this female somehow, and older the person, AF becomes more common than arteriosclerotic involvement. So definitely I would look for an embolic event, and I would also very diligently search for malignancy. I would like to mention also that very recently we had a case who had pulmonary TB, and then there was an embolus into the brain, young chap, 25, and the clot was extracted by mechanical thrombectomy, and in the clot we found AFB bacteria. So we don't know how it occurred. Maybe from the left side, it went into the left side of the heart, and then there was an embolus. And those emboli, the clot was extracted, and we sent it for histopath. And lo and behold, it was teeming with AFBs.
Maybe it's a PFO? Could it be PFO? PFO cause...
No, there was no PFO. There was no PFO. So probably, from the lung, it went into the left side of the heart. We don't know how it went, but that was a thing. Tubercular arteritis would produce more penetrating vessel infarcts.
Yes.
This appears to be a, M2, M3 type occlusion.
Correct.
So this is a large vessel occlusion. Or not large vessel, medium vessel occlusion. It's not a penetrating vessel occlusion that we see in TB meningitis. And anyway, there is no meningitis. So it's not TB meningitis. It's not a vasculitic infarct due to TB meningitis.
Yes.
So either it's cardioembolic or it is maybe precipitated by this drug.
Yes.
Which I didn't know of, I mean, these drugs now, there are so many.
Yes, sir. Yes.
We are neurologists, we don't know about these drugs and how they produce it. But maybe that drug did aggravate, but certainly I would cast the net wider and, look for malignancy diligently in this case.
Yes, sir.
And give anticoagulation once she settles down, maybe in 2-3 days. I would do that for her. And Aradhana, would you like to say something? Dhananjay, are you here? Or Dhananjay told me that he's busy in the ICU. He just sent me a message. So if he's here, he can talk. Aradhana, would you like to comment?
Nothing, sir. That's it. I had the similar questions about the malignancy, as D-dimer was very high.
Yeah. So this D-dimer somehow now, it is very sensitive marker for underlying malignancy.
Yes, sir.
So
in fact, I had sent D-dimer for that particular reason only.
Exactly. So maybe, you do those ovarian markers, CA, what is that? CA125 and something else, and do a CT of the abdomen. You may find something.
Yes, sir.
Tell us if you find something.
Sure.
Okay. So it's very interesting, and we are very happy that you took the decision of thrombolizing her, because she did benefit. In fact, is I would say moderate size. Its whole MCA is not involved. Yeah. Probably the whole MCA was involved. And, because you didn't do the CT angio at that time, you couldn't do it.
Actually, I was thinking...
Yeah, you couldn't do it. No? So it's okay.
I was thinking of taking her directly to DSA and do thrombectomy. But
I think we should...
liver dysfunction and coagulation...
We should give IVT first. I think there is no doubt now that IVT prior to MT is definitely superior. And many times we have seen that, you don't know that vessel may have opened up because of IVT.
Possible.
Because if NIHSS was 17, it is likely that there was M1 occlusion, because this in fact will not produce NIHSS of 17, And so it's very likely that IVT has helped her. And we know that tenecteplase given early, this is a little late, but earlier you give it. So that's why I asked you her weight, whether the dose was 0.25 milligram per kilogram or what.
No, sir, I use 0.2, little bit more than 0.2.
Yeah, I think we should give 0.25. Now there's enough data. Yesterday only there was, not yesterday, in that World Stroke meeting, there was another study called, what was it, Attach 2. They have shown that 0.25 they've used tenecteplase, and the study was for non-inferiority. It was not for superiority, but there was a signal. There was a signal that it is probably superior to alteplase. So it's not proven yet that it's superior, but definitely it's not inferior. And of course, ease of administration is there. So that is a big advantage. And I would go one step further and say that in many LVOs also, especially if given early and the clot is small in size, in length and porous, it opens up those vessels. So I am not in favor of doing, these. You are an interventionist, Chintan, so you may object to my statement. But many interventionists, they object to my statement. But I firmly believe that IVT prior to MT can, benefit many more patients, and we can save the patient from MT.
Yeah.
So, and in our country, with all its issues that we have of transportation, money, availability, etc., etc., IVT is with tenecteplase, I think, is a game changer.
In this particular patient, relatives were okay to go ahead with anything. In fact,
yeah.
But I did not want to take risk.
Yeah,
of
I think you've done well for her, because she's in ill health also.
Exactly.
Liver
Yes,
is bad, lung is bad. She's probably an open case of TB.
Yes,
So medically also she's not very sound.
Yes.
So the thing is, some will say that she's in such poor health. Why do you want to this thing? Why do you want to do thrombolysis? But thrombolysis has improved quality of life for many people, and even if MRS improves by 1 grade, it is cost effective. So I don't know whether she will survive with the TB and the ILD and the liver. I mean, that we don't know. We don't know the future. But I don't think we should withhold IVT unless there's a very, very strong indication, or if there's a malignancy and patient is going to die in 3-4 months, or if the patient is bedridden already, MRS is already 4-5. Those type of patients we won't take. But otherwise, I think we should take, and especially if the family is willing and everyone is on the same page, I see no reason why we should withhold treatment. I'm very much against withholding and not giving. Very much. Of course, people don't like sometimes what I say because they think I'm over-aggressive, but I don't think I'm over-aggressive. So I think, Chintan, you've done well, and very nice case, I must say. So maybe you can tell us the screening test that you did and tell us a little later. Okay. Dr. Atul Prasad, would you like to say something, sir?
No. I quite agree with everything. I would definitely have thrombolized.
Yeah.
I believe there's something called quality of life. Even if they are sick, they should have a chance to recover.
Exactly. So I think we are all agreed, and you've done well, Chintan, with her. And I hope she improves further. It's only how many days now?
Today is the 3rd day, sir.
Aha. So still a lot of time, yeah.
Yes.
She may walk, huh? Do good rehab. And look after her well. All the best to you.
Sure, sir. Thank you.
Thank you. Thank you. Dr. Aradhana, would you like to take your case?
Yes, sir. Yes, sir. Can you see my slides?
Yes, we
Yeah,
can.
we
We
can
can.
see.
Ma'am,
We
just
can
you
see
can
it.
click on from beginning once again on the left corner. Yes, ma'am. No, ma'am. Just beside that. Slideshow, ma'am. On the slideshow tab. Yeah. Yeah, ma'am. Please go on.
Good evening. I'll start with my case. It's a case of 58 years old gentleman who's right-handed retired government servant who was admitted at our hospital with slurring of speech, right-sided weakness on 26th of September at around 5:30 in the evening. He had these symptoms on 26th of September at 5:30 at Ratnagiri, basically, and he was shifted the next day in the morning after 18 hours of the ICTS to our hospital. On NIHSS, on admission, his NIHSS was 6. There was no history of loss of consciousness, dysphagia, diplopia, neck manipulation, neck pain, no history of any addictions. He was diabetic since 10 years, hypertensive since 1 year. He was taking his medications regularly. He had history of retinal detachment in the left eye 1 year ago, and he was treated with laser therapy. On examination, he was conscious and oriented. At the time of admission, his BP was 130/90. His pupils were equal, eye movements were normal, there was no nystagmus. His speech was dysarthric. He had right UM facial faint paresis. Power was grade 2 on the right side. Left side, it was normal. Right plantar was extensor. His routine investigations showed HbA1c of 9.4. Rest of the routine blood biochemistry was normal. His LDL cholesterol was 175. Albumin creatinine ratio was over 4,000. ECG showed hypotensive strain pattern. Chest X-ray was normal, and 2D echo showed moderate concentric LVH with 60% ejection fraction. This was his first MRI at our place. It showed bilateral cerebral peduncle infarct. It was predominantly on left side, although on the right side also we can see. This is the same patient, coronal section. It is restricting on diffusion. If we can go back, it is already started seen on the flare images. It is already 18 hours from the ICTS. We did his angio at our place, which showed proximal basilar occlusion here. There was left vertebral intravertebral stenosis also here. He was already started on dual antiplatelets at Ratnagiri, and we continued the same. It was aspirin 150 milligram, clopidogrel 75, and atorvastatin 80 milligram. He was stable when he came to us. There was no further deterioration. So we continued with the same management. The only thing is his BP was very fluctuating. It was fluctuating between 140/90 to 190/100. He only received amlodipine of 5 milligram once when his BP went to 210/110 in the night the next day. And it remained after that between 160/170 systolic to 90/200 diastolic. On third day, he deteriorated in the morning with worsening of speech. He also became drowsy and he started pulling secretions. At that time, examination showed that he was drowsy but was arousable to call. His pupils were equal. His dysarthria worsened so much so that he became almost anarthric. He was not obeying consistently and there were left-sided weakness now. This was his second MRI, which was done on 29th. It shows the evolution of infarct. The infarct is in the same territory, cerebral peduncle. It is more prominent on the left side, but right side, which was very faint, it became prominent now. So these are the same coronal images. As patient had increase in the size of infarct and the clinical deterioration, he was subjected for a DSA. DSA showed atherosclerotic changes in the basilar artery, which were diffuse, and proximal basilar critical stenosis were there, and slow flow was there in the basilar. There was left vertebral V3-4 junction stenosis, which was 40 to 50%. So this patient who had all atherosclerotic risk factors had acute onset stroke, which was not lysed, with an NIHSS of 6, who comes to us. And as he was stable, despite knowing that basilar artery stenosis was there, we didn't go ahead and intervene. We continued with double antiplatelets and statin, and BP was labile, so we were managing little higher MAP. So after this event, after DSA, balloon angioplasty was done, and stent was deployed at the proximal basilar segment. Patient was started on ticagrelor, and clopidogrel was stopped. He received IV tirofiban also during the procedure, and procedure went very good. It was uneventful. This was the procedure, intra-procedure images. This was an angioplasty, and this is the balloon at the segment of stenotic segment. And this is the pre-stenting status of basilar, which is showing proximal basilar critical stenosis, and this is post-stenosis, post-stenting. It shows a good vertebrobasilar circulation, which was restored. This was the immediate post-procedure CT brain, which was normal, just showing the dye here and there. Otherwise, there was nothing. After half an hour of the procedure, he had an hypotensive response in the ICU. The BP was 210/100, which was treated with IV antihypertensive drugs. We used bolus labetalol and enalapril. Almost 60 milligrams of labetalol was given, and 2.5 enalapril was given. BP was controlled within 30 minutes, and patient was stabilized. At around 4:30, after 3.5 hours, he had hypotension. There was no limb movement to pain. Pupils became dilated, and fixed dorsal reflex was absent. So repeat CT scan was done, which showed huge bleed. This was a bleed with intraventricular extension, and he succumbed later. So probable mechanism of action, mechanism of stroke here was probably atherosclerotic vessels. Along with the basilar, he had atherosclerosis of both ICAs as well. So right was showing critical stenosis, left was also showing moderate, and his posterior circulation, so we have seen already. So why we are discussing this case is, first and foremost thing is these typical hyperintensities that we could see here on the MRI are called as bilateral cerebral peduncular infarction, that is BCPI. It is considered to be extremely rare disorder among stroke patients. The imaging findings were described as Mickey Mouse ear sign by Asakawa et al. In 2013. The main mechanism of a bilateral cerebellar peduncular infarct is because of the large artery atheromatosis and a cerebral perfusion insufficiency. So going ahead, we can just go through this arterial supply of the midbrain. You can see lots of collateral and perforator supplies are there in the cerebellar peduncle. Posterior communicating artery, posterior cerebral and interpeduncular emi of PCA, which are the main blood supply of this cerebral peduncle. There are lots of case reports showing that bilateral cerebellar peduncular infarcts have a bad prognosis, and they worsen. They usually present with locked-in syndrome, and later they succumb. Although in our case, he succumbed to the bleed, but other case in these case reports also, they have said that despite lysing, despite doing successful plasties and all, they succumb. The prognosis itself is very bad. So in this study, what all the studies and case reports are mainly from the China. In this case series, they have described 5 patients in which all of them had these risk factors, atherosclerotic risk factors, hypertension, diabetes, dyslipidemia, all of them they had. Specifically, patients are elderly, around 63 or something, they had mean age group in the other case series. Here also you can see 55 plus patients are there. There can be additional infarct sites like occipital, cerebellar, pons, hippocampus, like in posterior circulation. And 3 patients where this angio is available, all the patients show basilar artery occlusion, and some of them showed posterior cerebral and vertebral artery occlusion. Almost all patients presented with decreased consciousness and tetraplegia. In these 5 patients also, 3 of them died, and 5 remaining 2 didn't have good outcome as far as the MRS is concerned. So reviewing the literature, there were 35 cases throughout the world from 1974 to 2019 which were reported in this syndrome. The average age was 65. Male to female ratio was 4:3. The commonest pathophysiology that we can correlate is atherosclerotic risk factors. All of them almost had it. Majority showed basilar artery and PCA thrombosis. And amongst this 35 also, 19 have died. 14 cases experienced vegetative state, and only 2 showed good prognosis. So we can say that when we see this characteristic MRI sign, we can say that probably it shows a poor prognosis, and it might help us facilitate early diagnosis and treatment. Early treatment methods like IVT may be considered, but still it's a question mark whether we have done the right thing or the wrong thing in our case also. And probably in this also, cerebral hypoperfusion is the mechanism by which the stroke occurred. So despite we maintained the blood pressure and MAP almost always more than 90, we don't know why he worsened, and probably the cerebral perfusion pressure and hemodynamic is still a mystery. Thank you, sir.
Yes, Chintan, can you?
What was the deficit before the procedure, before the intervention?
He had bilateral upper limb, lower limb. I think NIHS would be, I think this, more than 15, definitely. More than 15.
And consciousness?
He was drowsy but arousable to call.
But basilar artery was patent.
No, it was not patent.
You said it was 99% stenosis, but it was.
Yes, it was. It was showing the flow, but it was showing slow flow.
Yeah. Probably I would not have considered acute intervention in this case.
Yeah, that's what we also think. But he deteriorated despite that. What I don't know whether we did the right thing or wrong, but what could have been done when he would have deteriorated at that time?
I think blood pressure control is the only thing we could do.
But despite controlling his blood pressure, he
deteriorated. Reperfusion hemorrhage.
Yeah. Might be because of tirofiban.
Yeah, of course. See, these drugs are all double-edged weapons. No, you've given ticagrelor also.
Yes.
He was on the clopidogrel previously,
Yes, sir.
and plus tirofiban.
Yes, sir.
And I don't know, during procedure, heparin may have been
Also would
given.
have been used,
Yes, definitely.
Yeah, so all these are double-edged weapons, I mean, interventionists are always scared of stent thrombosis and things, but this BP, and that BP surge occurred, that was a Cushing's reflex. Probably he bled at that time, and therefore the BP went up. So, the deterioration was, but I think what you've done is correct. I mean, you couldn't have not done when he's deteriorating in front of you and the vessel is so bad. You could not have just left him like that. I would have also done the same thing. But this MRI picture is quite remarkable, and this Mickey Mouse sign is worth remembering. And Dr. Prasad?
I don't know if I would have intervened, not on day 3 or day 4 anyway. The mechanism of deterioration, I don't know, but the MRI did not show any new infarct. It just showed the same infarct which is evolving. So probably the cause of deterioration was hemodynamic only. Hemodynamic only. If this kind of a patient had come to me, see, posterior circulation is always tricky, and whatever you do is correct unless you lose the patient. But if this kind of patient had come to me, I would probably just have put on maybe antiplatelet and waited and washed. I don't know. Intervention in posterior circulation, I worry a lot.
That's why we didn't do it, sir.
No, acute intervention with already an infarct, no? There is high chance of reperfusion bleed, especially with so many antiplatelets on board.
Yeah.
So that is always a risk. So you're between the devil and the bird, deep sea.
Deep sea, absolutely.
You know, if you do it also, you're damned. If you don't do it also, you're damned. So I don't know what the correct answer would be, but
there's no correct
as you
answer.
said already that, you know, those Chinese patients, they never did well.
No, sir.
I mean, only 2 survived out of how many? 37, 35,
35.
40?
35, sir.
35, yeah.
Yes, sir.
So,
all of them received the standard treatment,
yeah,
double platelet statins, and control of their atherosclerotic risk factors. And despite that, there was only 2 who survived. So probably even if we wouldn't have done anything, I don't know.
Yeah.
Somewhere.
So I mean, that, see, we don't know. We don't know.
Yeah.
But I would have done the intervention.
Not on day 3. Maybe immediately. Maybe on day 1.
I would have only done that vertebral artery and just seen, because perfusion improved.
Yes.
There was hardly any perfusion going up, and PCAs were not seen prior to the intervention. Is that correct? Can you show those pictures again, pre and post? Yeah, let's see. 1 second. Yeah. So there was hardly any flow, and PCAs were not seen only. So it was a very badly diseased vessel, and post-stenting, there has been a terrific improvement. Of course, was he diabetic?
Yes, sir.
Yeah. See, there is arteriopathy. There is narrowing at this, which is this vessel? Superior cerebellar, which is this? Anyway, there is narrowing here. There are multi-level. You know, these diabetic vasculopathies, the vessels are too bad. You know, it's not only one vessel which is involved. So many vessels are involved, and the vessels are also very fragile. So diabetic for how many years you said?
10 years, sir.
10 years. And his HbA1c was 9 point something.
Yes, sir.
Yeah, so he was poorly controlled.
Yes,
so these vessels are extremely fragile and extremely tortuous also. You know, there's a whole loop. If you see this whole loop, you have to go through. And so the intervention is also difficult. But post-intervention, the flow is good. You know, all the vessels at the origin, if you see the origin of pica, pica is also very narrow.
Yes, sir.
PCA is also very narrow, or superior cerebellar, which I don't know what it is. But all those vessels at the origin, they are very narrow. Yes. So vessels are very bad.
Yes.
So therefore the prognosis will not be good, you know.
Yes, sir. Yes.
Even long-term prognosis is not good. And maybe, you know, I don't know, but on day 1, when that BP went up to 210 by 110, that, you know, not to give labetalol and enalapril, because that will...
It was given post-procedure, sir.
No, pre-procedure. Pre-procedure also it went up, no?
So we didn't give labetalol or anything.
What was given?
one Stamlo, amlodipine 5 milligrams.
Yeah, but there's no need to do that, because after that the BP went down, no, you said?
No, it was between 160, 170, 90, 100 diastolic. We went back and checked all the BP readings, whether it was...
Because no study has shown that acute control of BP, if you are not thrombolizing.
Not thrombolizing.
If you're not thrombolizing. So there is no end organ damage in the form of LVF or renal failure or dissection or whatever. So then there is no need to and that drop of BP even from 200 may be a defense mechanism, and then the BP drops even to 160 and then next day he deteriorated.
Yes, sir.
So I would not fiddle around with the BP too much. I mean, we observe it, of course, very carefully. And but now giving one Stamlo, I don't know how good it is, whether it really works or not, but and how long it takes to work. But, this drop of BP could have precipitated the worsening overnight. It could have. I mean, I don't know. There was no new infarct. So probably it was severe hypoperfusion. And because the vessels are very narrow, vertebral is very narrow, basal is very narrow.
Even
all the branches origins are very narrow. So there was severe hypoperfusion. And dropping the BP even by few points may have aggravated the hypoperfusion.
Yes.
It's possible. Now, see, nobody can be sure, but it's possible. So, and all studies have shown that control of BP should be done after a week or 2 weeks also, and there's no benefit of treating acute BP unless you're thrombolizing or unless it is astronomically high, which means more than 220 or 230, or there's end organ damage. So, ICU people are very keen to do something for the BP. So we have to hold them back a little bit and say, Are Baba, don't worry, nothing's going to happen so much. So that is one thought. Now, I don't know if I'm right or wrong. And many times, after giving, by and large, giving IV terofeban for a few hours and all, we've also given many times, nothing really happens. But now it happens sometimes, especially when you do it in acute stage. And this is a symptomatic ICH, and he is deteriorated due to that. So, when this happens, you spend sleepless nights and you keep on blaming yourself that should I have done it? Should I not do it? And you become the second victim. And hopefully relatives don't blame you. But, this is all part of the game of acute stroke care. So we need to face this music. Not all interventions succeed. We must be clear about that. There are problems. They need good ICU care. They need good support systems. All this, these are not easy things to develop, but we have to develop them, because unless we do that, these procedures are fraught with risk. So anyway, I think it's a very good case, and that MRI is very good. And I would agree with what you have done. Maybe a few points here and there, one has to be lit. I mean, we don't know whether what I said is correct or not. Nobody can. But maybe we could think about these points. Chintan, do you want to say something about this? You're an interventionist. Chintan is left. Dr. Prasad, anything you want to say?
No, I think we have covered everything. There's, like I said, posterior circulations are always tricky. And if the patient had survived, then everything would have been different.
Have you seen this Mickey Mouse sign? I've not seen this Mickey Mouse
sign. No, same here. First time seeing it.
So thank you, Aradhana, for showing us this. And so this Mickey Mouse sign is another good one. Just show it again. Let's see if it looks like really Mickey Mouse. No, the other. Wait a minute. Yeah. Now, where is the? Acha, these are the years.
Yes, yes.
Yeah, yeah. Okay. It needs a little imagination. But when I first saw it, no, I was amazed. Yeah, which vessel is involved? Is it the PCA which is involved? Which vessel? Perforators of PCA? Which vessel is involved here, Aradhana?
Lateral perforators, sir, from
Lateral perforators of the PCA.
PCA and basilar, superior cerebellar,
Okay, okay,
and
okay.
PCA.
I must say, this is the first time I've seen it. So thank you for that.
Very few.
And another thing I want to say is these Chinese, they are publishing like crazy in stroke. My God, they are beating the Americans and the Europeans. And we do that they are not, but they are publishing like crazy, and we are just nowhere. So they've shown 5 cases, and the same thing is there for so many trials that they have done. And all the Westerners think that all these trials are all fake and all, but when they replicate them, they are all correct.
Yes.
They replicate it properly. So China has made huge strides in stroke care, and especially these intracranial vessel involvement. I think they are head and shoulders above us. So we have to learn from them also.
So all the case series and case reports, almost everything is from China only.
Yeah. All these new studies and tirofiban and this and that, and everything is from China. So even scientifically they are forging ahead, and so their knowledge base is good, and they are working very hard, I must say. So thank you. I think as usual we have exceeded the time by a little bit, not too much. Dr. Prajakta, would you like to take over?
Yes, sir. So thank you very much for providing time for this meeting, and we are extremely grateful to you. And thank you for all the wonderful clinical insights that you have shared with us. I would also like to thank both the speakers, Dr. Chintan Prajapati sir and Dr. Aradhana Chauhan ma'am, for their excellent talks. And I'm sure audience must have enjoyed today's session. I would also like to thank Dr. Atul Prasad sir for his excellent moderation and sharing his expertise with us. Thank you, sir, for joining with us today.
Are there any questions from the audience?
So far we have not yet received any questions, but today we have total 315 people have joined virtually, but there are no questions.
315.
Yes, sir.
Which is a good number. I'm sure
yes,
they've learned a lot.
Yes.
Seen things they've never seen before.
And I would also like to thank audience for joining with us today, and thank you very much. And soon we will be meeting with the another interesting case discussion. So till then, thank you everyone, and good night.
Good night.
Thank you, sir. Thank you.
So today's session has also lived up to its promise.
Both the cases were excellent.
Thank you, everyone. Thank you, Aradhana. Thank you, Dr. Atul Prasad.
Thank you, sir.
And please come again for moderating.
Yes, I will. I'll come with the audience.
Yeah. Okay. All the best. Good night.
Bye.
Good night. Thank you, sir.